everyone. Thank you for hanging in there. We had some technical difficulties. Welcome to our webinar, finally. I'm Cynthia Milburn, and we at Epilepsy South Central Ontario want you to know that we're here for you and we're able to support you as always, just in different ways. Our support groups are on Zoom, and we seem to get along better than we have today, and other support, counseling, wherever the family or individuals are needing support, we're doing it through our virtual method. We wish everyone the best of health during this difficult time, staying isolated and keeping up spirits as best as possible. This is why we have a special guest today, Dr. Edward Bercovici, who is an epileptologist and the owner of Southern Ontario Epilepsy Clinic. He has been devoted to the community, being involved with patient groups and speaking to them about different facets of epilepsy care. He currently sits on the board of Epilepsy South Central Ontario and is the medical advisor to Matthews Friends Canada. Both Dr. Bercovici and I are available for questions throughout the hour, and if you could make your questions general in nature, avoiding anything personal, we will make every effort to provide the information to you. Please also try to limit yourself to one question as time permits. This is a remarkable opportunity for all of us because it is rare that we can have the ear of such a specialized epilepsy professional and are able to ask questions directly. We are very privileged to have you here, Dr. Bercovici. And just a reminder, our topics are potential drug shortages, COVID-19 and epilepsy, and managing stress and keeping out of the ER. Dr. Bercovici, would you like to give some overall comments, and then we'll facilitate some questions? Right. Welcome.
Thank you. So thank you very much, Cynthia, and to the Epilepsy South Central and the Facebook community. I wanted to thank you all for having me come, and this is obviously unprecedented times. So I'm glad that we're able to still provide ongoing care, both from the community and the medical point of view, to our patients who are struggling with seizures and epilepsy. As you can see, I'm in my clinic at Toronto Western today. Just in the middle, just finished seeing patients all virtually. So obviously this is unprecedented times in how we see patients and how we try to manage this condition. So I think that with everything that's going on with the whole COVID-19 pandemic, obviously there's a lot of questions and concerns. And one of the main issues is around the pandemic and what does it mean and what is the stress of it. So I think I'll tackle that first because I think that's one thing that we need to sort of address is the elephant in the room. Obviously, the pandemic has altered how we communicate with each other. We don't shake hands, we don't go out, we don't travel. And I think that obviously makes things different for everybody. You know, people who rely on a close circle of friends, or in this case, the community agency, are not able to attend to that physically. And that's obviously, I appreciate that ESCO is still trying to do things virtually, such as this. Obviously, this is creating stress, and it's very difficult for me to say, you know, don't be stressed. We're all living through this together. I'm not an outsider of this condition, as you guys are. So we're all in this pandemic together, and I mean, part of that is that we're all united in that. So there's not one person that's, you know, not being affected by this to a great extent. And I think that we need to be mindful of our own stressors and our own worries. You know, because it impacts how we do it. So, I mean, when I leave this room, I have to put a mask on and gloves, and, you know, I have to see all my patients through telemedicine. And, you know, obviously that's not the most ideal way. I can't just sort of turn over and see them next to me and shake their hands and examine them. At the same time, obviously going stuff and getting groceries is becoming stressful. So I think that it's important, I think, for us to make sure to find ways of how to manage with our day-to-day activities, be able to combine our activities so that way, if you're worried about going out, you can minimize things like going get your groceries and your prescription medications. You know, we can still try and go for walks. Exercise is very important. You know, although we're told not to congregate in big groups and being in a large area full of people, we can still walk around the block. We can still walk around in certain areas. So I think that's been helpful both for, you know, de-stressing, mental health, physical activity, and also, you know, help you sleep better. I think finding a few key people to talk to is obviously important, and obviously this this unprecedented time has put a toll on how we communicate as human beings. I mean, we going back to to our roots of talking on the phone and trying to do as much as doing face to face, but and trying to be able to still see people's expressions, trying to talk to them and go through all that is still very important. I mean, even if we're going to say a neighbor and see, say hi to a neighbor from across the street, it's still worth it. I mean, just still have that communication. Obviously, if things are getting bad and you find that your stress is getting really bad, it's important to reach out to a medical professional. And obviously, there's a lot of people out there that can help you with that. Because what we don't want to do is avoid addressing these issues. What we're seeing is as we're seeing less people coming to the hospital because they're worried, and what we don't want to do is having that second wave of medical problems because a person has been ignoring things. So I know that to address the elephant in the room with respect to the COVID-19 pandemic has been, well, am I going to be getting more seizures, or what is my risk? And these are very complicated questions. I mean, there is the neurological manifestations of COVID-19. So there are case reports and then rare cases of things happening to someone from a neurological point of view because of COVID-19. And those are obviously very interesting to academics and research. But I mean, to the average patient, it's not that you are more likely to get a neurological issue. So if you think about this as an infection, someone who's sensitive enough that they're going to get seizures during infection are more likely to get seizures. But obviously, the key thing for all of us is to make sure that we just take care of ourselves, and so that you're not being run down. And so if you're more likely to get seizures because of sleep deprivation and you're staying up all night worrying about the COVID-19 pandemic, that's going to trigger more seizures. So I think we want to make sure, I think the key thing at this point, what we want to make sure, that we want to take care of ourselves in that way. And then obviously with the pandemic is making sure you get your medications, which comes down to a whole shortage. There are no, at this point, active shortages. We've had shortages over the years with clobazam, valproic acid, et cetera. At this point, what we're seeing is that the government has enacted this regulation to provide only 30 days worth of medication at a time to really minimize the potential shortages. And so I think one of the questions is, what do you do if your pharmacy is basically saying to you, you can only get it for 30 days? It's making sure that they're stocking up on that medication, that when your 30 days comes up, if you need to get it, that you're able to get it in time, and that they're not going to say, well, I'll take another few days for it to order in. So to make sure that they're stocking up on it. And especially if it's a controlled substance. So there's certain medications that are controlled, like benzodiazepines, phenobarbital. Those ones sometimes need a few extra days to be released. So you want to make sure that the drug prescription is written on it, that it can be released a few days earlier, so you don't have to wait until the last minute to get to it. Especially nowadays with these pandemic, that the pharmacies are also minimizing their hours. So we have to be mindful of that. So I think, obviously, we have to make sure we don't want to stockpiling medications. We want to be able to make sure there's enough medications for everyone. And at this point, I think I'll turn it over to Cynthia and to determine what the next options are.
Okay, we have several questions, actually. The first being people having difficulty sleeping. And so they're wondering what's the best way to kind of help with their sleep. It's obviously they've got anxiety and stress due to COVID-19 and sort of an uncertain future. And so the question is, can melatonin or CBD oil conflict with epilepsy meds? Okay. And how could they sleep better?
Okay, so these are very good questions. Again, I'm not going to be specific to any person's condition, but rather in general. As I mentioned, the sleep is becoming a big problem in general for all of us because of our devices. I mean, obviously, the irony of it is I'm, presenting on this on people's devices. So obviously, I appreciate the irony of it, but we have to appreciate the fact that we are staring at these screens at a very close distance, and the activation of those screens really essentially blocks melatonin, and so you're able to, or it affects your sleep quality. So you want to be able to set some cutoffs. So if you're trying to lie at night waiting to fall asleep, and what you end up doing is staring at a screen, especially when the blue light filter is off, you're more likely to affect your sleep quality. And so just taking melatonin is not going to necessarily be an answer to that. So there's something called sleep hygiene, meaning, minimizing what you do in bed. So for example, like not you doing stressful things in bed, work, those kind of things, really using bedtime for sleep, making sure that you are able to find a way to relax in bed, and obviously it's comfortable, make sure it's comfortable, make sure that the room is dark. I know these are such obvious things, but making sure that the room is dark, lights are off, you don't have the alarm clock flashing at you, and what we want to make sure is that those things have to be done. Sometimes a face mask or earplugs can help in some patients. I think the challenge of melatonin is you have to make sure there's no interaction with the medication you're on. So I know that CBD is obviously a hot button topic, and we can spend a whole hour just on CBD. But I mean, it does interact with some medications. So for example, CBD can impact clobazam. So it can actually inhibit the breakdown of clobazam's byproduct, downstream product. So I think that's we have to be mindful of the fact that just because it's natural does not mean that there's no interaction. So we have to be mindful of these kind of these things. And again, it's hard for me to just say, yes, this will work for everybody, because for some patients, CBD is an activator. For other patients, it's not. For some patients, they describe that. So I think this is something you have to take back to your doctor and make sure there's no interactions before you start something like melatonin or that. Obviously, I know it goes without saying and about the caffeine issue. Now, I know that caffeine has been asked by many patients. It's not that caffeine triggers seizures, but obviously most people who drink excessive coffee are not just because they like it, but rather because they're compensating for, let's say, poor sleep. So if you're, for example, staying up late, not sleeping, trying to study late or work late, or you just can't fall asleep, and then the next day you're drinking a lot of coffee, well, then what's going to happen is going to be a vicious cycle. So really, we have to make sure that we cut the coffee or caffeine down before bed. And there's obviously, if you're really sensitive to caffeine, so there's a lot of hidden caffeine in chocolate, and even decaf coffees would have caffeine. So I think just being mindful of that. There are other natural therapies that can help. We just don't want to be dependent on certain things. I mean, there's some those like Benadryl and Gravol. We don't want to necessarily be dependent on those kind of things.
Good answer. Wow. There's several more questions. One is to do with the drugs. What do you do if your pharmacy does have a shortage of one of your medications?
I think those are obviously very those are very challenging questions, and the problem is as a doctor, I mean, I give a prescription, and the patient goes to the pharmacy, but I don't know what their pharmacy tells them. So if the pharmacist comes back and says, well, that drug is not available in my pharmacy, how many pharmacies have they tried? How many distributions have they tried? So for example, I had a patient that said that they couldn't find valproic acid liquid, but then I had another patient today that I said, well, do you have it? And they said, no, we definitely have it. And the pharmacist never told us there's any issue. So the question is, I mean, I can't send all my patients on wild goose chases, especially I'm being mindful of the fact that some of my patients don't drive. So, and with, with transit, with pandemic, it's obviously very challenging. So I kind of would encourage the patients to talk to the pharmacist and really, advocate for yourself, saying, listen, I can't drive, or it's very far from me. Can you please find me someone else who does it? Find another, because it'll be actually more challenging for the pharmacist to expect a doctor just to change your medication. So I know that when clobazam had a lot of problems, I've got a lot of requests just to change for something else. But the problem is that something else is going to have side effects. That something else is going to have issues. And so just a switch is not that easy. It's not like switching between Tylenol and Advil. There are ramifications for switching medications. We better be mindful. So I don't think that it's just that easy. So I think we have to kind of go out of the way to really find that medication. And again, make sure that you're on top of things and let the pharmacy know that, yes, I will need this medication for the next long time. Please make sure to stock it up, and please make sure to have it. Even if you're not releasing to me every 30 days, make sure you have it in your shelf. And I think that's a challenge. And I've talked to some of the companies for some of the newer medications, and they're assuring me that there is enough of the medications that have recently been released. So the companies have told me that they have enough, and the ones where I've heard that there are not enough, I've reached out to those companies to give me some feedback as to what's the if they have enough, and so I think that we need to go through that and be able to find something. And again, doctors are obviously helpful, but we don't know what the pharmacies have, and we don't have a centralized pharmacy system.
Here's another question just regarding seizures and learning and the current learning and a lot of screen time for these kids. So the question is, when it comes to seizures and learning and being on technology a lot, it seems to be affecting some children's memory and increasing episodes. So besides decreasing, how can they teach their kids? I even have an answer to that actually, but go ahead.
Sorry. Yeah, I mean, it's the challenge, of course, with learning and technology, as you said, it's if you have someone that's very sensitive to technology or they're being distracted. So the problem sometimes these technologies are distracting. So it's very easy for us to switch screens, and constantly be distracted. And distraction is the ultimate problem with memory. Is when you're constantly being beeped on by your machines or another pop-up coming tell you have a mail, and you just want to look at that for 5 seconds. Well, now you've impacted that learning algorithm in your brain. We all have an idea. So if I tell you 10 words to remember, and in the meantime, a bunch of tweets come up and you're interested in it, you're not going to be as good as if you just sort of buckle down and just sat down and learned those 10 items. So, and these are the challenges. Distraction is a big problem. And again, especially because we use our screens as a fun tool. So it's hard to kind of switch between a fun tool and and something serious. And we know that because, I mean, just even people in their office, on an everyday office, are having problems with this. Sitting down on your computer, knowing that you can sit at home and switch between just take a little break and watch 5 minutes of that binge show you're watching, or then listen to a tweet and then going back to your work. And I think those are big problems. So the issue, I mean, if you're having that difficulty, and if there's a paper option, so for example, if your teachers say, well, you know what, you can do this on paper or the computer, and if that student does not learn well on the computer, then perhaps just maybe alternating and doing a bit of paper. So I mean, just being able to sort of say, okay, let's just take this math problem and let's just print it out if you have a printer, and just go through and print it out, and then go through it in paper, and then come back into the math, there's something online, and alternate. That way you could not always constantly on the computer screen, which it's going to reduce eye strain, minimize that distractibility. And Ms. Cynthia, what were you going to add?
Well, I was going to say, because the school curriculum, if it feels too daunting, you're in the same boat as everyone else. Right. Which means your children will not be left behind. And I'm hearing that homeschooling is very hard, and especially kids with learning difficulties and special curriculums. And this time's an opportunity to learn in different ways. A lot of learning is done outside the classroom, so parents they're telling me they're including their children in cooking, baking, gardening. So this involves measurements and properties of baking, and all about seeds and plant growth and gardening. And if your child has special interest in something in particular, have them do some research or some project that makes the day meaningful, and just try and get through this whichever way, but they're always learning. So, I have another question here. How long do you think
before you do that question, I just want to finish off with one thing that I just you also triggered in my head, because I mean, I've had some patients, and I'm not a pediatric neurologist, but I do have patients that do have learning disabilities and autism, and some of the parents have had challenges, especially with school being out, and especially because some of the students are in school till 21. The key thing that some of the parents have been successful at is really keeping that routine. And so making a routine and keeping a routine. So even if it is school, through e-learning or as you said, just like real life learning, having a routine, so that way they're not just sitting on the computer screen watching TV and YouTube, and then they're going to go back to a computer screen for school, but rather saying, okay, you're going to help me do this, and you're going to use that as a teaching moment and spending time together, but really creating that routine for them. So I think that they can then look forward to that every day. And I think that these are the challenges times, as you said, and everybody's in the same boat.
Yeah, I think we're all finding a routine is helpful to keeping sane throughout this. There's a question about elective surgeries. How long do you think elective surgeries will be shut down in Ontario due to this COVID-19?
Unfortunately, this is a very good question, especially if I know for the epilepsy point of view. I think that that we are a bit far away at this point. But I do think that some of the elective surgeries, depending on how elective they are going to be being brought back in. And I'm not sure what the government's going to do in terms of testing. To be honest, I'm not a public health official, so this is going to be on me to guess. I just hope that, and I think there's going to be a tiered approach. I don't think they're just going to start it off right away, because the elective surgeries being closed has allowed us to open up more ICU beds, because those beds are not being used for elective surgeries. And so we now have, good capacity, and as the numbers are trending down, the hope is that we can then start to open up the elective surgeries on a slow matter. And I'm hoping our elected officials will provide us information about that in the near future, especially for our epilepsy cases. I think where we are patients that are waiting either for intracranial electrodes or for lobectomies. We want to make sure that we can provide that care to try and really get that good control of the seizures.
Okay. Should someone experiencing seizures speak with their doctor about a prescription for rescue medications, even if they have not previously used rescue meds before, in hopes of staying out of the emergency room?
So this is a good question, and I can speak about the whole concept of trying to keep my patients out of the emergency room. I think that's has been my goal. In some cases, it's been providing medication. Other times, it's been deferring medication changes. So I think the challenge, of course, depends on each patient and their seizure control. So if the patient's change of medication will be mostly for side effect reduction or something like that, or just because, let's say, pre-pregnancy planning, some patients have opted to just say, let's just wait a few more months until we can get a better handle, because if that person gets a rash and that rash ends up going to the hospital, they're more now apt at being exposed to potential exposure to COVID. And I think that's obviously some worries patients, which it's fully understandable. So I think I've made a lot of deferrals of medications that are not necessary, or not necessary at this point in time, but it could be deferred until later. Whereas if this was a regular time, we wouldn't have hesitated. But in terms of adding medications, yes, I mean, I think in some cases the rescue medication can be helpful. It depends on the seizures. It depends on whether they cluster. Depends how long they are. Depends on comfort levels with the family with managing it. Because the problem with rescue medications is you don't want to use it in place of an emergency room. So if someone is going to go into status, and you know that they're going to go into it and have never used it, you worry about them delaying the onset of the treatment that will abort it. Also, if someone has other things I have some patients where the seizures are usually triggered by infections. Well, we know that then what they need to do is find that infection, and so that we don't want to delay that treatment. In other cases where I think that the challenge has been is basically if someone uses too much of it, right? Because what a rescue medication is usually a strong benzodiazepine, and what we don't want to do is put that on someone who's already very sedated and then affect their breathing. So we want to make sure that that person has a rescue medication, but also a reasonable approach to what are we going to do and how we do it. Because what we don't want to do is call the ambulance, not just for the seizure, but because of a breathing problem. So I think it's a balance you have to do. And I mean, there are times when I've had to prescribe rescue medication because a person lives in a cottage on an island and there's no way they're going to get care for 3 hours. And I think those kind of situations, but we have to, it's individualized. Each person is different, and we have to try and be realistic in one sense, avoiding the emergency room for seizures, but in another sense, making sure that we have a plan for the seizure, but also sense avoiding side effects from that rescue medication, which can be more severe sometimes.
Very good. Just a lot of questions here. At what age would you know, or could you know, if you will have epilepsy for the rest of your life? Like for a child,
So very good question, very challenging question. The prediction of our ability to get someone with to require medications, it's very challenging. I mean, I can just even look at today's roster of patients, obviously without breaking confidentiality, but I had a patient where he just had temporal lobectomy, and the question is, when is going to be the time to wean off medications, or maybe just keep them on one medication. Then I had another patient where they have a genetic condition and they have only small minor seizures and they're actually not on any medication. So, I mean, they still have epilepsy, but they're actually managing very well. Then another patient who was transferred to me from pediatric neurologist, and they ended up having a trial off medication several times. And the question has been, well, they failed the trial, so how long do you keep them on that? So these are the challenges, I think, with some of our conditions. So there are certain conditions where I will never see them as an adult neurologist. So for example, benign epilepsy childhood spikes, or lambic spikes, pardon me, or most childhood absence epilepsies, majority of these conditions will resolve by the time I see them. There are some benign childhood epilepsies that I'll never see because they just outgrow by 14, 15, 16, etc. And there are some that I've attempted to be weaned and can't be weaned. I have patients where we've successfully weaned them off even when I met them, and they're for some reason they just get better. So there's certain conditions like juvenile myoclonic epilepsy where we know that that majority of patients will need to be on medications, but there are a small fraction that don't. And the question, I guess, is finding that time, and when is that time? So I don't like to sort of say, I don't like the word for the rest of your life because it implies a negative connotation. But I do think that we have to be realistic to some extent and look at the numbers. And it depends on the condition, if it's focal, if it's generalized, if it's caused by a previous lesion in the brain or an infection in the brain. There are certain things where it will have a better prediction than others. So we can't just sort of lump all epilepsy into one.
Okay, there's some people wanting to know how to get an appointment with you, and they just would like to know what area you cover.
Okay. So I have a website, and it's www.seizuredoc.com, and that information can be put on, I guess, by the organizers later. There's referrals on that website. I do cover, I work very closely with Epilepsy South Central Ontario because so we work very closely well together because I cover the same area as they cover. So I work in the west end of Toronto. So I just on the Mississauga border. And so I cover the Halton Peel region, but also patients from Kitchener-Waterloo. But I have patients all the way from Ottawa to Timmins and beyond. So most times we try and do telemedicine. And I guess the one good aspect of this pandemic has been that it's really tested our ability to rely on these telemedicine appointments. So I rarely see patients physically now in the last few weeks, but we've done a lot of telemedicine appointments. So we've been able to really get good at doing it. And so I have patients that are 5 minutes away doing telemedicine and patients that are normally 6 hours away, and we were going to do telemedicine anyway. So now we're able to provide that care on an ongoing basis. So I think that I think location-wise is not necessarily the biggest problem. It's just more or less whether or not you like me.
Well, I think everybody does.
Everybody does, but it is.
There's a question for both of us. How do the epilepsy agencies work in relationship with neurologists, such as yourself? And what does our agency do? So we provide counseling and support for people living with epilepsy and their families and caregivers. And we have several programs. Our website also you can go to and see what programs we have. And when we work with Dr. Bercovici, for example, or Hamilton Health Sciences, we have other some pediatric neurologists in the area as well, who we have a referral back and forth. So we would do what's called a clinic to community program. So the neurologists rate on diagnosis, they refer to our agency, and if you're located in Toronto or in York, you would be referred to that epilepsy agency for immediate education and training, and this alone will keep you out of the ER for I think the stat is 38% of the time. So it is a really good connection and relationship that we have with each other because we need each other. Dr. Bercovici doesn't have the hour and a half in the clinic, whereas we do. So it's a really, really important relationship that we have. You wanted to elaborate, Edward?
As a neurologist, I typically, I would see other patients with the various things, migraines and Bell's palsy and numbness and tingling and vertigo. As an epileptologist, my specialty is epilepsy and seizures. And this is one of those conditions where it's very difficult to do it or do a great job just without the community agencies, because they're the ones that patients reach out to have the support groups, the teachings, the information. They have pamphlets, they have, they have get-togethers, and some patients don't want it, but a lot of patients do appreciate it, and a lot of patients will reach out to them and get that information. And it's nice when they're getting the same information both ways, and it's nice when they can relay it back, or they can say, hey, I have not been able to reach so and so, can you help me out, or what, how else, what's the best way to approach this, what's the best way to approach that. I've had the community agencies help with employment support, provide letters and for schooling, etc. And so it's nice to have that, because I think it makes for a crucial relationship. This is especially when you're dealing with chronic conditions. And any of you have heard my talk at Epilepsy Durham know that about the discussion I had on chronic conditions is that it's not just the seizures. You have to look at how this condition affects the person and how this affects them, how they deal with the world and the driving and the work and the school and the family. And so I think there's so much aspect of this condition that we have to involve the community agency to really help to integrate that and to integrate the medical part. And as much as I'd love to be able to spend an hour and a half with each patient, and some of you I have spent an hour and a half with in one sitting, it's a challenge, because we don't have that time, and we want to be able to obviously get to everybody on time, and it's a challenge. And sometimes I can't get to certain patients, and they're not happy with that, and sometimes they appreciate that time. And I think that's where we want to be able to also rely on the community agencies. And the challenge, of course, is the fact that there's so many different community agencies all over Ontario, but making sure that you are dealing with the one that's relative to your location, so you can easily connect with them.
Okay. A question a while back. It's a little too personal for us to address, but I'll generally, due to COVID-19, I mean, if you can imagine this child was diagnosed on March the 18th. So that's a traumatic time to be diagnosed with epilepsy. And so the first diagnosis, and then they're going through EEGs and PET scans and MRIs, and then they ended up with a genetic testing of KCNT1. And so there's, the challenges with COVID. I'll just loop it in with there, and I will encourage the family to contact us after this, because we can definitely help you out. But just in general, a diagnosis at this time would be quite traumatic. Well,
no, go ahead.
Did you want to elaborate, or we can?
No, I think you covered it.
Talk offline, because that family definitely has lots of questions. Mm-hmm. So there's a question on SUDEP, another elephant in the room. Do you, Dr. Bercovici, provide info on SUDEP, and they're asking for feedback on chance of getting it. So, I mean, we always tell people to be compliant with their meds and their regime, but you might elaborate.
Yeah, and that's exactly the cause. That's you had patients say, well, what are the chances of dying with seizures? And obviously that it's an opening line, and 10 years ago, nobody would say, oh, no, nobody dies from seizures. And now we're realizing that doesn't necessarily mean the case. Now, obviously, there are the issues around injury and trauma. And that's obviously a different aspect of seizure care, for like safety issues, about if you're having frequent seizures, avoiding baths, avoiding swimming, avoiding high places, not hanging around the top of the stairs. I know they sound so common, but I mean, but these do happen, and unfortunately, I've had some of my patients suffer from these. But there is this new entity that's gaining wide research interest, and for unfortunate reasons, and that's called sudden unexpected death in epilepsy. And the idea is that there are some patients where they have very frequent tonic-clonic seizures. So that's one of the big risk factors is tonic-clonic seizures, or they used to be called grand mal seizures, where for some reason the seizure tends to affect other parts of the brain, and they would then have a respiratory depression, cardiovascular issues where the heart and lungs essentially stop. And it's very unfortunate, because it's not the seizure itself that makes a person suffocate, but rather the the seizure activity in the brain triggering off those kind of things. So we as Cynthia mentioned, the importance obviously is being compliant. So we know that one of the big risk factors is compliance. There's no particular medication associated with it, but it is the tonic-clonic seizures. We do know that if someone's had these epilepsy longer, they're more at risk. Patients with developmental disabilities are more at risk. And the number of medications, which is a correlation to the severity of the epilepsy. It's unfortunate. I have lost a few patients with this, and it's hard. It's hard on everybody, and it's unfortunately not something that we can prevent it per se. Meaning, we obviously want to talk about it, but aside from if someone really has tried so many different medications and not a surgical candidate, and they're having, let's say, a few seizures a year, they're still at risk, and it's not something that we can just sort of say, take this pill and that would minimize the risk. The risk is 1 in 1,000, slightly higher in patients, as I mentioned, with those risk factors, but it is there. Often I typically will say things like making sure that we use precautions in bed, making sure that family members know CPR, making sure that you minimize, I always say be a minimalist in bed. Like, for example, less pillows and not a lot of duvet covers. I know that some people like these heavy blankets, but obviously that's a bit of a challenge if you're constantly having seizures at night. So those are the things that we have to talk about. But it's important to bring that up to your doctor and really being informed. There's SUDEP Aware, which is the website. There's a bunch of SUDEP organizations, and so it's obviously a very important condition, part of the condition to be aware of.
Okay. Somebody's asking a question. It's a very they're very desperate. So they're asking their daughter gets seizures in that first 15 to 30 minutes of sleep, and none of the AEDs are working. She's tried several AEDs and no improvement. So how do we move forward?
It's a very good question. We do know that we're more epileptic during sleep. So during the sleep onset, so some patients are more epileptic during sleep onset. In general, our brains are more synchronized during sleep than awake. And so for example, there will be like some patients are more likely during that first part of the initiation of sleep, which is why a lot of times we want to capture sleep on an EEG. Sometimes there's some more patients have seizures when they wake up, like first thing in the morning. So one condition, for example, is called tonic-clonic seizures on awakening. I guess it depends. I mean, without getting to the specifics of the condition, it depends on the condition itself, because some patients will need different medications, and sometimes there will be a particular medication that'll be better than others. One maybe that has a quicker onset right before bed, like a benzodiazepine, or certain medications are given before bed. So there's different medications, and it also depends whether it's focal or generalized, because some medications may not be good for focal, for generalized, they're more focal, or et cetera, back and forth. So I think we just need to be more, to bring that up to your the neurologist. I'm assuming it's his daughter, I'm not sure how old, but your neurologist or pediatric neurologist to kind of go through and make sure that they're on the right medications. I don't know if other options are available, surgical workup. I know that in some conditions, CBD, in some conditions, ketogenic diet. So there's different options for different conditions. Sometimes we also use VNS in these kind of situations where the medications have failed and there's no surgical option.
Yeah, okay. Someone's asking, I've heard the term status or status many times. Could you please explain exactly what this is? So the word status, S-T-A-T-U-S, is a short version for Statusepilepticus, because there's other statuses. There's status migrainosus, there's different statuses, and Statusepilepticus is a medical emergency. It is a seizure that that persists beyond a certain amount of time. And I'm being vague here because basically this has been a contentious point. So people, before you say half an hour, then 15 minutes, but we do know that a majority of seizures will end within a minute or two, sometimes 5 minutes or 10 minutes or 15 minutes, depends on what kind of research you use. But if a seizure doesn't stop by a certain amount of time, you have to go to the emergency room because it won't stop. Now, that said, there are certain patients that have
epilepsy partialis continua. These are very rare conditions with focal status. So, I mean, I have had patients that just have like an arm jerk for days on end, weeks on end. That's not, I mean, they're already on medication. We're not going to treat that. But a tonic-clonic seizure that doesn't stop or keeps going back and forth without, that's a medical emergency that needs to be treated because there's metabolic derangements, there's different issues that can happen, oxygenation issues. So those kind of things. So status epilepticus is something that we need to jump on very quickly.
Okay. Is there any kind of technology you can use during the night to monitor for something like SUDEP?
It's a very good question about monitoring. So there are some different options for monitoring. During the night, the challenge with monitoring has been because if the person is not falling, then a fall assist is not going to necessarily our fall detector may not pick it up. There is something that is available in the US, and again, I'm not trying to promote just one company or another, but the one that I've seen in the conferences is something called Embrace or Seizure Watch, and there's a similar option for the Apple, I believe, and other smartwatches. But for example, the Embrace or Seizure Watch is one that detects movement, so you detect the shaking. The challenge, as I said, that sometimes the patients may not have a seizure with it, or maybe a small seizure that's not detected. So I think the challenge with SUDEP is that we don't have a good way of detecting what's going to happen. We don't have a way of detecting that person other than having, let's say, someone monitoring them or a bed partner or something like that. Or, you know, some patients, I know they've had oxygen monitors, but again, they're not as helpful because most of oxygen does sort of reduce a little bit during sleep, but not significant. But again, it doesn't necessarily mean you have to all go buy oxygen monitors because it may not be sufficient. So I think that the challenge is that there are detectors for seizures, but not necessarily detectors just for the SUDEP itself. Do you have anything else to add to that, or I don't know what your thoughts are?
Oh, who, me?
Yeah.
There's different monitors out there, and there's different manufacturers, and we could post some of that on our Facebook page. Okay. For people. Yeah. We have time for a couple more questions, and then we'll offer some closing remarks. The next question. Okay, so someone who's 19 years old, been on meds since age of 2, now hasn't had a seizure in 4 years. Doctor's wondering what if or wanting to wean them off. So they're on Tegretol and clobazam. Which is better to come off first?
I mean, unfortunately, I cannot provide that information specifically to your case. It all depends. There's multiple reasons for it. It depends which one was added first, which one worked. So sometimes it depends if Tegretol was added first and didn't work, and clobazam was added second, and then the one that stopped the seizures. Because if it is, then it may not be the one to come off. It also depends on the reasoning for it. So if someone is having other side effects, then that might be a reason to reduce the medication. The other question is if and when. So meaning is the 4-year mark enough? Has the EEGs shown any ongoing activity? So there's a lot of other factors to figure out which medication and when. It also depends on the dose too, because if someone's, it may just be weaning down a dose, not just completely off. So there's a lot of other aspects, and that's not going to be a straightforward answer, unfortunately. So it has to be, I think, one of those things that has to be individualized. And every time I've had to wean someone off, it's always been a bit of a challenge, and we've always individualized it specifically to figure out when the medication was added, which one helped, which one didn't help. Because even when we in the epilepsy monitoring unit, a drug that someone says, oh, this one didn't help at all, all of a sudden when you reduce that medication, the person has a lot of seizures. So I think these are the challenge things when we're dealing with medication changes or withdrawal.
Okay. I don't see any more questions on the chat box here. We would like to let everyone know again that Dr. Bercovici's website is seizuredoc.com, and it will be on our Facebook page, and it's very easy to find. And next week we will be doing a session with Jennifer Fabe, the president of Matthew's Friends Canada as well. She is the registered dietitian facilitating the ketogenic diet at Mac Children's Hospital, and that will be on May 7th at 4:30. And the topic will be medically supervised ketogenic diet and epilepsy. And that's ours next week. To speak further or to log in to see Dr. Bercovici, again, tomorrow Epilepsy Toronto is doing a webinar as well. So they will be continuing the conversation and probably talking to some different topics. And so, you know, we'll be back to work at Epilepsy South Central Ontario with the new normal. I assume it will resume slowly for all of us. And there will be greater reliance on technology, more virtual meetings and counseling and support groups, especially initially. The positive to this is the instant response you'll receive, and that you won't have to travel to see us as if because that's quite often a transportation issue. And donations can be made through our website, and they will help us with the COVID-19 Emergency Response Fund to help offset our loss of revenue from a continued list of canceled fundraising events, which we're dealing with at this time. I would just like to thank Dr. Bercovici for taking this time with us. You are truly full of knowledge, and we're very, very thankful that we have had the opportunity to have you on. And we're very privileged, and this is one of the positive things that have come with the situation now, because we're reaching out in this way.
Thank you much for having me. I hope that this was useful for our audience, and I hope that we can continue the discussion. I would love to do this again if you want to have me back again, and if this has been useful for the community. And after this, it's back to work for me. So back to doing more paperwork. So thank you very much.
So much. Thank you so much.
No problem. My pleasure.